A very good morning to one and all, and I'll be dealing about the unsettled debate, that is in Shakespearean language. If you ask to resect or to placate, that is the question. So let me take it in a simple way. You have a waist measurement that is always changing, and you have bought a pant or a skirt which you don't want to throw away if you get fatter. Then you think of putting a tuck on it so that you can change it at any time you want, so it's a bit easier. So you don't have to cut it and alter it. Instead, you just put a tuck, you remove it, and then you can even fit into that dress even if you are out of shape. So the same applies here. Muscle strengthening procedures in large can be divided into resection and plication or tuck. Tuck was initially described as muscle-to-muscle plication, and plication is reattaching it to the sclera. So it was described as early in the 19th century. It was revisited by and popularized by Dr. Kenneth Wright and revisited by Dr. Joseph Deemer. In resection, we cut a part of the muscle and then reattach it to the insertion. So there is a risk of lost muscle once the sutures give away, and there is a disruption of the anterior ciliary vessels. So that might be an issue in certain cases. And in tuck, the muscle is attached to the muscle and it's not attached to the sclera, so we decrease the length of the muscle. In plication, this is a pictorial representation. The resection part is marked, sutures are taken with a double-armed suture, and it is passed at the muscle insertion, and it's tightened. So this is actually a more easier procedure and less messy too. And these are the steps of plication. We hook the muscle as usual, take the bites at the desired location, and we have put a iris repositor just to press the muscle, and the sutures are passed over the sclera. The bites are taken at the sclera and it's tightened, and this is the final result. So it's considered as less invasive procedure. The muscle is not disinserted from its insertion, so there is an advantage of sparing the ciliary vessels, and it is folded and sutured onto the sclera at the insertion. So there are a lot of studies which promote plication. The first study is by Dr. Pamela Houston et al., in which horizontal muscle plication produced a similar result in ocular alignment. The surgical success was the same. And there is another publication in IJO which says the same. And a comparative study has been done in the Japanese Journal of Ophthalmology between recess versus resect, so as a procedure for intermittent exotropia. All these are for plication. And the advantage is you can use the same tables as resection for plication. It produces almost the same effect. So the surgical dosage is the same, and that also has been described in papers. And so plication has been used for vertical muscles too. Another topic of issue is whether this anterior circulation is actually preserved or not. So there has been a study of anterior ciliary artery circulation in humans, and this study shows that rectus muscle plication spares the ciliary vessels. So that is an added advantage. So the other side of the coin is there are other studies which prove that plication produces a lesser effect, and it is not, it produces a lot of lateral incompetence, increased resurgery rate. So they conclude that it is necessary to have a long-term study before changing over to plication. So what would be waiting over on the other side? Is it without side effects? No, or side effects or surprises. It might give away, and you might have to take the patient in for a replication. And there may be a swelling at the plication site that usually subsides in few weeks. And there might be a small bump in the plication site that also subsides usually within few weeks. So apart from the usual, plication has been described in other situations like using a rectus muscle plication with adjustable technique, so that gives another room for adjustment. And plication augmentation has been described in Hammersheim procedure also for and in abducens and Duane's, abducens palsy and Duane's. So these are also been described. So is it actually a substitute to resection? It may be, because it is less invasive and has more or less the same effect, and can be done in cases where multiple recti need to be tackled, because it saves the anterior ciliary vessels to some extent. And are we really concerned about having an alternative procedure to resection? Yes, because it gives us an option to release, especially in the immediate postoperative period, so that we can revert. So that is a procedure which we can undo. So that is also important in strabismus surgery. So it gives us a room for rethinking also. And it's an option to spare the ciliary vessels, so that's an added advantage. And it is less invasive, and there is no necessity for disinserting the muscle, and there is less risk of the muscle being lost. So these are just two cases in which resection has been, plication has been done instead of resection, along with a recession of the lateral rectus. And preoperative, he had a 35 prism base in with a small L by R. And postoperative, after plication, I just did a recess because the L by R was small. Postoperative, he had around 4 to 6 prism diopters the first day, and after 1 week, he was almost same, 2 to 3 prisms of esotropia. So this was a constant esotropia patient, and this was done in an intermittent exotropia patient in which he had a little bit of binocularity, and the first postoperative period, the same of around 4 to 6 prisms of ET was there. And this is a picture few months after the surgery. And in this, no lump can be seen at the site of plication. So it's as good as the other eye. So it doesn't produce any side effect. That is one side effect that has been described, a small lump at the plication area. So it gives good results. After 4 months, he is ortho with the glass. So to conclude, plication may be an alternative to resection, and anterior ciliary circulation is not compromised. It is a less invasive procedure, and it is easier, and it has the potential to be reversed at least in the immediate postoperative period. So thank you to all my teachers who have made this possible, especially to Murli sir for making this instruction course a possibility. And thank you, Indore, for the hospitality. Thank you.